Bonsoir.
Good evening. I'm pleased to be here this evening to talk about this topic. I'm a psychiatrist. I've been a psychiatrist for 35 years. I am specialized in palliative care. I am also at the Faculty of Medicine. I have directed a department during 8 years. I'm also working in palliative care and research. I am the director of the Quebec Research Center in Palliative Care. In my brief, I began with a clinical demonstration. I described a type of patient, a patient that is found in articles, someone who has their limits. She has been struggling for 20 years. She made several suicide attempts and no treatment has been successful. She says she wants to die. And yet her path changes unexpectedly. She has cancer and realizes she doesn't exactly want to die. She ends up developing a significant relationship with a volunteer in the palliative care center. This changes her perception of her life and of her illness. That's what we are trying to say here as psychiatrists with great experience. We've seen suffering throughout our careers. We have a therapeutic and technological and pharmaceutical arsenal available, but in psychiatry, we also are able to offer people who are suffering with a therapeutic relationship, and this can change a life. It is therefore difficult to differentiate between an autonomous and authentic desire to access MAID from other problems. As illustrated by this case, uncertainty is part of psychiatry in diagnosis. Even for a very severe case, like the one I described, something unexpected could happen, and we need to remain open to that. We need to maintain hope. Therefore, the criteria of irreversibility does not apply to mental illness. Moreover, refusing treatment is an intrinsic component of illness. It is frequent that we find ourselves required to treat patients against their will and they improve. Therefore, this is part of illness. Opening up euthanasia for mental illness could lead to complex and rare cases. Studies show that we have frequent psychiatry cases like depression, social difficulties, poverty, socioeconomic class. All these factors play an important role. This has possibly led Quebec to hit the brakes on this path. It is also difficult for the care team, patients, and families. There's a lot of suffering and sadness. Over many years, compassion fatigue may set in. These elements form the mix in which it is difficult to take such a fundamentally irreversible decision. Moreover, palliative psychiatric care, unlike physical medicine, does not come with many trial or new types of treatments. For example, psilocybin or neurostimulation practices are very new, and as a director, I've seen that these methods could be promising. This expansion feels inappropriate and dangerous because these decisions are fatal. They are deadly. Doctors ethically need to...
Terminé. Donc,
Indeed, I'm at the end. In terms of modern medicine, many jurisdictions, including Quebec, are closing the door on euthanasia, and it should be the case for all of Canada. Thank you for your attention.